Medicine and the Department of Global Health and Social Medicine. In his current role, Dr. Cancedda is focused on establishing and supporting programs and projects that advance the health of people in Botswana and that are aligned with the priorities of key local institutions like the Ministry of Health and Wellness, and also programs that are designed to serve as a catalyst for transforming all participating institutions and ultimately leading to improved and sustainable health outcomes. Dr. Cancedda has extensive background in leading global health teams throughout sub-Saharan Africa. For 4 years, he served as Director of Training and Medical Education in Rwanda at Partners in Health, where he was one of the chief architects for the Human Resources for Health program, an innovative health professional training initiative that successfully built the health workforce in Rwanda. And he also served previously as the Executive Director for the Partners in Health Ebola response in Sierra Leone. Dr. Cancedda has his MD and PhD in immunology from the University of Genoa, Italy, and trained clinically at the Albert Einstein College of Medicine and in infectious diseases at the Washington University in St. Louis. So for our session today, Dr. Cancedda will speak for about the first half of our session, and then we're going to leave plenty of time in the second half of the session for questions and answer. So please, throughout the talk, feel free to put your any questions you have in the chat, and Mike, Arista, and I will be moderating the discussion portion. And so with that, I'll turn it over to you, Dr. Cancedda, and welcome, and thank you for joining us.
Thank you so much. It's really a pleasure to be here. So let me share the screen. There you go. Can everybody see? Okay, there you go. So it is really an honor to be here. This is the title of the talk, which is Hierarchy of Qualities in Global Health Partnerships. And I would say, first of all, well, what is a global health partnership? We can define it as a multi-year working relationship between two or more organizations from different countries, all sorts of organizations, right? Governments, multilateral organizations, universities, NGOs, et cetera, et cetera. Now, this is a profound question, actually. Why are global health partnerships important? And they are important, I would say, for a couple of reasons. First of all, many countries and communities do not yet have all the resources necessary to meet the health needs of their populations, but also some challenges, and I think the current COVID-19 pandemic is a perfect case in point, are of such scale and complexity and or span across national and geographic boundaries, such that no country and community can tackle them in isolation. And I would say it's not by chance, right, that partnership is the last of the Sustainable Development Goals, right after institutions. And a way to think about it is that you really can't achieve, well, definitely the third SDG, right, the health SDG, SDG 3, without strong partnerships and institutions, but you also can't achieve the other SDGs, many of which have an impact on health. We're also in a critical transition phase in global health, right? It started with tropical medicine, which ended with the end of colonialism, terrible legacy, we all agree. It continued with international health, which ended with the Cold War. You know, these are the years of the Almata Declaration, the great vaccination campaigns, but also of extremely flawed concepts like selective primary care or cost effectiveness that kind of torment us to this day. And then, you know, the next phase is the so-called golden age of global health, right? These are, you know, catalyzed by the HIV/AIDS pandemic. These are the years of the Millennium Development Goals first, and then the Sustainable Development Goals. And, you know, I would say starting with the Great Recession, but definitely with the current COVID-19 pandemic and climate change, we're kind of being propelled in a new World Health era. This paper that I'm quoting is pre-COVID, but I think it's still very actual. And of course, over the past few years, key concepts like One Health and Decolonizing Global Health have become really, really, really prominent. And the question is, how should global health partnerships evolve with this evolving landscape? And it's not a rhetorical question. It's not an academic question. It's a very practical question because we got problems. I think you will all agree. Half of the world population still lacks access to essential health services. 8 million people die each year because of low quality of care, HIV, tuberculosis, malaria. We made progress, but they're not eradicated, nor they are under control, really. Neonatal disorders, it's a major cause of disability-adjusted life years. Maternal mortality is not progressing as much as we would like. At the end of the day, really very little has been done at scale to prevent and treat NCD, cancer, mental health disorders. And of course, we didn't respond well to COVID at all, and we're not responding well to the negative impact of climate change and environmental health degradation on health either, right? And even on a personal level, it's really not an intellectual exercise, an academic exercise. These are some of the activities, projects that I've been part of all over the world. And, you know, I've experienced really good partnership and extremely lousy ones. This tree is outside of what used to be an Ebola treatment unit in the town and district of Porloco in Sierra Leone. Each ribbon represents an Ebola survivor. And when in September of 2013, a small team for Partners in Health, which included myself, joined forces with a wonderful local organization called World Body Alliance. The country of Sierra Leone was really in the middle of a devastating epidemic of Ebola. And this particular district, the district of Porloco, was experiencing over 200 new cases per week, which was the highest transmission rate ever documented. The government of Sierra Leone was running this Ebola treatment unit basically on their own with very little support. And of course, it was poorly staffed and poorly equipped, and was providing a minimal level of care and was very unsafe, both for patients and for health professionals who were at risk of catching Ebola and in fact did catch Ebola. And from the beginning, Partners in Health and World Body Alliance decided to actually work with the government of Sierra Leone, not to build our own Ebola treatment unit, but actually to work with them to increase the safety and improve the quality of care of this facility and other public facility. And this was kind of contrary to what most other international NGOs did. And it was riskier, it was quite the undertaking, but we felt that it was the right thing to do. And one of the donors, which shall remain unnamed, praised this approach. They had actually asked us to pretty vehemently to work in this facility, and they said that they would continue to support us. And so over the following 5 months, we admitted almost 2,000 patients. 600 of these patients approximately ended up having Ebola. We saved half of those. Half of those walked out of the Ebola treatment unit. And this was by far the busiest Ebola treatment unit in the country. Then all of a sudden, one of our staff members got sick, caught Ebola, and we had to evacuate this person to the United States to get care. And several other staff members who had been exposed had to be evacuated as well for quarantine and monitoring. Hopefully everybody did okay, but it was a very scary time. And the same donor, all of a sudden, accused us, I would argue really wrongly and unfairly, of being irresponsible and reckless, threatened to pull their funding. Now, they didn't do it, but I will never forget the sense of deep betrayal that we felt in that moment. And of note, when a few weeks earlier, 2 government staff members got sick, the donor didn't raise any concerns. And what happened really got me thinking. First of all, was I ever that kind of partner to someone else? But more broadly, like, how can we expect to build meaningful partnerships in many of these countries when so many partners have like a track record of such behavior. And other people, more experienced, pragmatic, more worldly than I was at the time, they sort of said, well, what did you expect? And my answer at the time was, and still is, that we should expect better. Another way to think about it, if you try to define what are sort of like the principles at the heart of any healthy relationship, even between people, right? Say what you mean, do what you say you're going to do. And my favorite, do not throw each other under the bus the second things get a little difficult, a little uncomfortable. If you were to take these principles and apply them to global health partnerships, how many would actually pass the test? And my sense, and I think you would all agree, that there's actually a real cost to lousy partnerships, a cost that we don't really measure and therefore we likely underestimate. And there's a benefit to good ones, and we don't measure that benefit either, and we likely underestimate it too. Now, in recent years, there have been several attempts to generate new evidence on the secret sauce for successful global health partnerships. Globalization and Health had a whole series on the subject, and they did a systematic review on the so-called institutional health partnerships. And their conclusion was that the evidence for their effectiveness was thin, both in terms of quantity and academic rigor, and really that most of the papers on the subject were expert opinions, advocacy pieces. Very few were systematic reviews. The Tropical Health and Education Trust came up with a set of guiding principles for global health partnerships, right? They should be strategic, harmonized and aligned, effective and sustainable, et cetera, et cetera. I mean, they sound great, they make perfect sense. The Consortium for Universities in Global Health came up with a 10-step framework, identifying champions and a core team, developing a strategic plan, obtaining institutional support and baseline funding. That too, I guess, makes perfect sense. The European Esther Alliance developed this evaluation framework that groups global health partnership based on their thematic focus and program scale. And this is where some of the partnerships that I was part of fall under. And I'll talk about some of those later. But my colleagues and I felt that, or we just decided to contribute to the existing literature with a paper of our own. And we felt that all these very sensible principles and steps maybe could use a little more elucidation and conceptualization. So first of all, kudos to my co-authors, Simon Schrigger, PhD student at Penn, Fran Barr, a qualitative researcher at Penn, Agnes Minaguao, Global Health legend and Vice Chancellor at University of Global Health Equity, Moses Ketile, Deputy Permanent Secretary at the Ministry of Health, Vanessa Carey, CEO of Seed Global Health, Joel Mobiligi, Country Director for Partners in Health, Doreen Ramogola Mazire, she's the Deputy Dean at the Faculty of Medicine of University of Botswana, and Michelle Rowland was CDC Country Director in Botswana. And what we did, we had semi-structured interviews with these 7 global health experts. The inclusion criteria was having at least 10 years of experience and having managed at least one multi-million-dollar program or initiative. And it was a mix of high income, middle income, and low income countries. And folks were working at government agency, Ministry of Health, donor organization, academic institutions, NGO, was pretty diverse group of people, right? The interviews had 3 questions. What are the key qualities and ideals of a global health partnership? What are the benefits of upholding these qualities and ideals? And what are the costs of failing to do so? Everybody was interviewed twice. We reached theoretical saturation after 7 follow-up interviews. We identified themes and sub-themes which we conceptualized as qualities of pillars. And then we developed a theoretical model for successful global health partnerships. And everybody provided specific examples like real life scenarios of lessons learned and best practices. And again, we identified these 12 pillars, and we developed a theoretical model that was inspired actually by Maslow's hierarchy of needs. So the way it works is that some pillars, governance, resources and expertise, power management, transparency, accountability, data and evidence, respect and curiosity, they must be present in the early stages of a partnership, the transactional level. And other pillars like shared vision, relationship building, deep understanding, trust, they develop over time and allow the partnership to mature from the transactional level to the collaborative level. And the last two pillars, equity and sustainability, allow the partnerships to mature to the transformational level, analogous to Maslow's, I guess, self-actualization stage, and achieve its highest potential. And of note, when we talk about equity, 50-50 or win-win is not equity, right? The idea is that the partner with the greatest vulnerability and the least agency should benefit more and faster. When a partnership is transactional, the primary focus is really on organizational benefits. And by default, the partner with the most power benefits the most. In a collaborative partnership, the focus is also is not only on organizational benefits, but also societal good, and the benefits are distributed somewhat more fairly among the partners. And then ultimately, in the transformational level, the focus is really on the greater societal good. And there's significant redistribution of power, I guess, between the partners. And the partners need to change their practices like profoundly. They can't just like tweak them, adapt them. Like this, it requires really like a different way of operating from the status quo. These are some quotes from the paper, and I would say none of them are really like surprising. The interviewees provided examples of, good things that were happening and bad things that were happening. And if we start with the bad, again, lack of coordination, of course, a major issue. International partners, like, they're unaccountable. They kind of like to do their own thing. But sometimes governments, they're not really willing to coordinate them or are unable to do so. Excessive turnover of staff has negative impact, of course, on health service delivery. Donors have their own agenda. Often it's covert. They don't really own it, and they kind of determine at any given point the parameters for when and how the money should be spent. Politics can be incredibly thick, incredibly fraught. And a lot of international partners, of course, don't take the time to really understand the culture, alienate people, and this hinders implementation, hinders progress. Now, on the good side, if you give people really like space and time to articulate their needs and lead, or at least participate in the planning process, you really cultivate ownership. Investing in a relationship is messy, takes time, but ultimately it's the right thing to do. It's a rewarding endeavor. It's a worthy endeavor. And flexibility is key because it implies the willingness to sort of meet each other halfway, step out of the comfort zone, do things differently when it's necessary. And then, of course, the judicious use of resources and expertise, and the gradual and well-planned transition of responsibility from international partners to local partners achieves sustainability, right? And these three sentences are sort of like different takes on the same concepts. Now, the key question really is, how should partners act in a transformational partnership? And again, I mentioned this before, but what's critical is that it's a little uncomfortable. It should be a little uncomfortable, maybe even a little more than a little uncomfortable. Everybody should really be willing to step out of the comfort zone and do things differently, even profoundly differently. So donors, consider funding more for longer with less strings attached, Fund national governments and local organizations. Avoid driving the agenda. Academic institutions, maybe consider rewarding impact as much as academic productivity. That's a longer conversation. International NGOs, of course, accept to be subprime on grants, play really a supportive role to local organizations. Leave if you're not, if you're not needed. National governments increase funding devoted to health, but also lead and coordinate development partners. And then I think everybody at every given time should ask themselves, with the commitment of actually answering the question and doing something about it, what can each one of us do differently that will allow us collectively to achieve the greater good? How are we willing to change practices? And traditionally, I don't think I'm saying anything particularly original here. The burden of changing, and we call it capacity building, has fallen really on the partners with the least amount of power, underfunded ministries of health, understaffed health facilities, poor and under-resourced communities. But really in a transformational partnership, the burden of changing and of building one's capacity should be democratized and spread equitably across all partners. And I would argue, if a partnership is under-delivering, the partner with the most power probably should change the most, right? It seems self-explanatory. Now, the question, was I ever part of a transformational partnership? And what about the current partnership, the Botswana-UPenn partnership? So you may have heard of the Rwanda Human Resources for Health program. It was a massive 7-year initiative. It was launched in 2012 and sought to train thousands of health professionals in Rwanda and basically completely refurbish the health workforce. And it was a transformational partnership. Well, first of all, simply because of the scale of the initiative, but also because every partner really stepped out of their comfort zone. Like they really did things differently. Looking on the left of the slide, the white square in the upper left corner, 18 US universities deployed hundreds of faculty, and many of these faculties really in specialty areas or subspecialty areas that have very little global health footprint. So they had to sort of create a home for them and support them and mentor them. This was really, really challenging. And then the donors, that's the bottom left corner, PEPFAR and CDC, they channeled $150 million, not to the US universities, but to the government of Rwanda. And the government of Rwanda, through the Ministry of Health, that's the gray square in bold, they managed this whole thing, really, like they ran it. And it was massive. And working with the University of Rwanda, they also ensured its sustainability by recruiting some of the newly trained Rwandans as faculty and promoting additional partnerships and collaborations with the US universities. Now, the US universities were organized in a consortium, so this was really highly coordinated, and each one of them contributed to a different specialty area, subspecialty area, or health discipline. And as a result, 22 training programs were either started from scratch or enhanced. And after 7 years, there were over 300 new physician specialists, 3,700 nurses and midwives, over 260 oral health professionals, and over 120 health administrators. Now, what about the Botswana University of Pennsylvania Partnership, or BUP, how it's known? The history of BUP has obviously evolved over time. It all started in 2001, which with the HIV pandemic, right? At the time, Sub-Saharan Africa was being devastated by the pandemic, and Botswana, in particular, was among the hardest hit countries. And these are the years also of the Millennium Development Goals, the Global Fund, and PEPFAR. So initially, and not surprisingly, the focus was on prevention and treatment of HIV and tuberculosis. Eventually, as people with HIV and tuberculosis started living longer, and also as Botswana started taking ownership of the HIV program, our focus shifted to other diseases. And of course, in recent years, Botswana released Vision 2036, which is their roadmap to become a high-income country. We are in the middle of the SDGs, and then we're in the middle of COVID-19 pandemic. So how BUP evolves to achieve these goals, meet these challenges, will determine its future. Our scope presently is quite broad, as I mentioned before. We diversified what we do. So we work across several specialty and subspecialty areas, health disciplines, even sectors outside of health, like dermatology, internal medicine, oncology, pathology, pediatrics, trauma rehabilitation, and we do a combination of research training, health service delivery. Our staff presently is roughly 70 people, 90% local. There's 5 faculty, 10 core operations staff, 55 project staff. And before COVID, we had approximately 100 visitors from Penn faculty and students, but also visitors from other institutions. We're slowly going back to that baseline. And we recently celebrated our 20th anniversary, and we had a very successful symposium at the end of 2021, which, again, not by chance, was called Transformational Partnerships, Health Equity and Sustainability. And of course, it was a wonderful opportunity to celebrate our successes, the achievements of the past, many of which long precede my tenure, right? Like a lot of amazing people led PIH led BUP over the years. But it was also an opportunity to sort of rethink our strategy going forward. We had come up with a strategy pre-COVID, but it was kind of derailed. So we felt like we had to go back to it. And when we thought about our strategy, we sort of asked ourselves the question, how are we different? Like, what is it? What is it about us that really adds value to Botswana? And one answer that we gave us is that maybe we can try to do partnerships a little different, or focus on partnership, because everybody values partnership, right? And that really for us, partnerships would be not only a way to do things together, but a catalyst to transform the institutions and organizations that participate in them, all of them. Of course, we may still opt to do something that someone else doesn't do, like, I don't know, cancer, or work in a new geographic area like the Kalahari Desert. But at the end of the day, it really would be about partnerships, the way we partner. This figure emphasizes the idea that, you know, all the organizations that work through BUP, that they will be able to advance their strategic priorities and the SDGs. But of course, the strategic priorities of Botswana are more important, and that's why that circle is bigger. And we also develop a theory of change, right? So the way it works, and again, start on the left of this slide, is that let's say that University of Pennsylvania and a partner in Botswana get together for a project. If the partnership is based on some of these principles that I mentioned before, equity, accountability, empathy, data and evidence, you name them, then one outcome will be that the project will be implemented well. That's the long gray arrow in the center of the figure, and it will advance health, right? That's the green square, SDG 3. But another outcome will be that the partner in Botswana, at the end of the project, hopefully will have strengthened its capacity to implement and scale a similar project on their own, or even with another partner if they choose to do so. And at the same time, University of Pennsylvania, at the end of the project, might be able to support other similar global health projects and even implement them with other partners elsewhere. And elsewhere could be in other low and middle income countries, or even in the US, because as we will see, there's a lot to learn about health equity in the US. This is our mission statement that sort of captures everything that I talked about before: improving health in Botswana and beyond through the power of partnership. And these are the goals, and they're pretty self-explanatory. I kind of joke that it's kind of like saying world peace, But the idea is that everyone that works through BUP, that comes from Philadelphia or even from other academic institutions in the US to work in Botswana through BUP, they need to be able to articulate how their work will advance these goals. Improve access, coverage, quality and safety of health services delivered, strengthen capacity in Botswana, strengthen capacity at Penn, generate and disseminate new knowledge, and improve the effectiveness and the quality of the partnership. And goal 5 is key. It needs to be its own goal. Like partnerships are not a means to an end. They're an end in of itself. And you really want to make sure that the partnerships that we establish uphold the principles that I mentioned before, because without strong partnerships, we can't achieve the other goals. And now we have a bunch of working groups, each one focusing on a particular area of engagement, that are coming up with objectives and activities for the next 5 years, and we are engaging our partners in countries, right? That's the part in red. And we're trying to strike the right balance. We don't want to overwhelm our partners in countries or unload on them responsibilities that are ours, right? To plan and be thoughtful. But we want to make sure that everything that we do serves a higher purpose for Botswana. And it's an interesting balance. It's a complicated balance to strike, but a very important one to strike. Now, going back to the third goal, strengthen capacity at Penn to sustain and scale programs. I want to expand just a little bit on this, because I think there's 3 layers in which one can interpret this. The first one, it's pretty easy, right? There's a demand by Penn faculty and students to engage in global health, so BUP offers a platform, sure. The other one is that maybe BUP can help University of Pennsylvania to establish systems, pathways for global health work, like global health fellowships for junior faculty. But the third level is more philosophical. If we look at health outcomes in West Philadelphia, which is the catchment area of the Hospital of University of Pennsylvania, also known as HOP, life expectancy in certain parts of West Philadelphia is actually lower than Botswana. HIV outcomes, Botswana is actually achieving the 90-90-90 targets from UNAIDS, right? 90% of patients with HIV have a diagnosis, 90% of those are on treatment, and 90% of those have undetectable viral load, and Philadelphia is not even close. And to be honest, this is not just an issue with HOP. Many major academic medical centers in the United States have life expectancies and even measures of universal health coverage that are worse than the average of the United States, but also of countries like Botswana and Rwanda. And I was actually thinking about the schizophrenia of an ID doctor from one of these academic medical centers that gets funded by PEPFAR to go to countries like Botswana and Rwanda to push to achieve the 90-90-90 targets, while in his own or her own clinic, their own clinic in the US, the patient population is not achieving that targets. So why is that? And really, one could ask the provocative question, why aren't the communities served by some of the best teaching hospitals in the world, among the healthiest in the world? And of course, a lot depends on social determinants of health, not access to or quality of care. But even that is not a good excuse, and I'll be happy to talk more about it in the Q&A session. But I also wonder, are global health and health equity really primarily a commitment? Or are they still primarily like a niche in the market? And how can program and initiatives abroad re-energize the fight for health equity domestically? There's been broader call for the social accountability of academic institutions, especially in rich countries. And the SDGs are really fascinating to me because they're ever present in international development and even in global health to an extent. But they're completely absent, barely a footnote when it comes to accountability of academic institutions, definitely in the US to my knowledge. Lastly, I've been asked to sort of comment a little bit on, my own background. I'm a white guy, middle-aged from a rich country with a colonial past, and I'm talking about Italy here. So how am I dealing with that? And it's a great question, probably deserves a much longer conversation. Again, I'll be happy to take questions in the Q&A session, but these are some of the ways that I'm trying to deal with it, to do my best. So the first one is, of course, be aware of power differentials and blind spots, your own, but also those of others. Understand that business as usual means outcomes as usual, including injustice as usual. Have integrity in your own choices. Own what you think is fair and what you think is not. Make partnership and power management the focus of your work. Be honest and profound in your critique, but fair and thoughtful. Provide critique to others the way that you would like others to provide it to you. And then I think this is really, really important. Offer, but also expect solutions, and even better than solutions, a standard to uphold and a path towards redemption. Thank you. Thank you very much.
Corrado, that was amazing. Thank you so much for your insights. I just in the private chat that I've received, as well as the applause that you see in the Zoom, I think people are deeply grateful for your perspective. I wanted to give an opportunity for folks to if you have comments or questions, please feel free to raise a hand or add your comments to the chat. So by introduction, my name's Mike. I'm one of the coordinating team here at UCSF, along with Naomi and Arista. Corrado, I was hoping I could start by asking you a question. And in fact, as somebody who worked for BUP in Botswana for 3 years, I'm really delighted by the evolution that has happened there. But you mentioned that the burden of changing has to fall, or has fallen historically, on the partners in the dyad that have the least power or the agency. And then you said, partnership that is under delivering, needs to change, and the partner that should change is the one with the most power. How should we do that? How and who should be assessing that assessment of success? And I think you mentioned, like, number 5 on your list was the quality of the partnerships. How do you assess the quality of global health partnerships, and then how do you build capacity of the powerful partner in a dyad who may not be motivated to have their capacity built? I'd love to get your perspective on those things.
Amazing question. The answer is little by little, but relentlessly. Oh boy. Yeah, listen. First of all, when you provide critique, even of institutions like Penn, UCSF, Harvard, try to be constructive, and because like, at the end of the day, like, most of the people that work in these institutions, they want to do the right thing. It's just that the business model, like the makeup of these institutions, like the incentives, those are off, right? And I think point to that, like, in your critique, point to that, and also, like, be honest. Like, I work for Penn, like, they pay me nicely, and they're paying for my master in public administration. They're doing a lot of great things, right? So they're partners too, right? Like, even the partners that you critique, they're partners in this fight, right? That's, I guess, yeah, that's the short answer. But then also, like, be radical, like, like, just point out to the nonsense, like that ID doctors get funded by PEPFAR to go to African countries to say achieve 1990, and the catchment area where they work, we're not even, like, in the neighborhood of 1990, is insanity. Okay, and that's okay to say. Like, so it's really, like, threading that balance. And then, like, be honest with yourself. What are you prepared to give up? And that's tricky because it's just so easy for, even in an institution, right? As powerful at Penn, there's a gradient of power, and junior faculty are, more vulnerable than, the dean of the medical school, and medical students more vulnerable, and if they're minority, like even more vulnerable. But I think each one of us, also need to be honest. You know what? I'm going to care a little less about tenure if, like, writing all this paper at the end of the day doesn't change a thing in the world. And I'll just try to do what I think it's important. So yeah, again, I don't know if that's a satisfactory answer, but, like, critique outward, but be fair. And then critique inward. And I think, even when you critique people with power, just understand that the enemy's power is the power differential, it's not the people. And that whenever society has a huge power differential, the people at the top and at the bottom just see the world differently, and power does something to you, right? And just like in a sense we suspend disbelief, when we go to a poor community, like we don't judge, right? We understand that if I was here, it would be the same, to an extent. It's also just critique power, that really power differential is the enemy.
Yeah, that's very insightful. I see that maybe Sharon has come off mute. Did you want to say something, Sharon?
I did have a question. Thanks, Mike, for noticing me. If you had the job of designing the professional development of everyone in the Global Health Bureau at USAID, okay, and you had come after a large global health career to believe that mindfulness is the only thing that actually matters in terms of that power sharing, how would you go about influencing that donor group? What would you want them to know, do, feel, think?
Oh boy. All right. We're talking like dream world, okay? Like really like the ideal world?
Maybe not,
right.
Maybe not.
All right, well, let's say that let's say that I run USAID, okay? Or PEPFAR. All right, you take the map of the world, you're gonna have a pot of money. First of all, try to get 3 times that amount, 10 times that amount. But okay, you have a pot of money. You sort of split it by country by burden of disease, okay? And then you go to that country and you say to the government, okay, this is the amount of money that you have to take care of your health priorities for the next 5 years. Pick your international partners and come to me with like a plan to address them. And, I have these parameters for you. After 5 years, I want you to be able, to pay for 30% of this, okay? And we'll keep supporting you at 70%. Something like that. And take 6 months, take a year to figure this out and come back to me. Because right now, these grants are insanity. Like, there's a CDC, well, I don't want to name names because it's not helpful, but...
It's okay, too late.
Okay. You get a grant and it says, you have 2 months to figure out how to spend $20 million and completely like transform the HIV program. Go. And then you have like all these like NGOs that already work in the country, they kind of like hover around the grant trying to like come up with something. It's impossible to engage the government in any meaningful way. So you end up writing something, half-assed, sorry for the colorful expression. You get the money and then post-mortem, you figure out actually how to make it meaningful. And then the donor often after you get the money comes back to you and says, you know what, scratch it because these are my priorities now. You just can't, it's just like the whole system just doesn't work to the degree that it works. Now, I don't want to be too negative, like PEPFAR is the greatest thing that happened in global health and the world is better because it's there, but we could do so much better.
Corrado, there's a question from Karen Kwok. Karen, do you want to come off mute and share your comment? And then there's a couple in the chat that I'd love to have you respond to. But Karen, over to you.
Thank you for this opportunity to speak, and Mike, for the organizers of this event. I am really interested in the potential role of funders in convening the network of change agents in the area. So, with the training of the trainer models, have those been implemented with the Rwanda and Botswana groups, where there's a cross-pollination of regional actors so that they get to know each other, that they can collaborate amongst one another for a sustainable, strengthened health system? Thank you.
Yeah, no, it's a great question. I mean, I love trainers because, of course, you know, you can't always have people from a country that has certain knowledge and expertise to go to a country that doesn't have it and like do the training. Eventually, you're going to need some local trainers. But again, I think, and you know, the DHRH program that I just talked about, we did trainer of trainer. But I think, you know, you really want to think about institutional capacity strengthening, and training the trainers of a university, for example, is just one element of institutional capacity strengthening. The institution needs career development paths for these folks. They need an IT infrastructure. They need grants management teams so that they can write their own grants and then manage them, right? So you really want to think about these things more systematically.
All right, I think we have time for a couple more questions. Carol Camlin, do you want to share your question which you put in the chat? Over to you, Carol.
Sure, thank you. Thanks so much for this really inspiring talk and challenging talk. I wanted to ask you about some of the thoughts that you have about where training happens and how to set up training in a way that is, equitable. And there are kind of counter arguments for training happening in wealthy countries versus training happening in LMICs, and calls for reversing directionality as a kind of post-colonial, anti-colonial practice. And on the other hand, there are negative consequences of that. So I'm just curious about your thoughts about that.
Yeah, no, I mean, it's a great question. I think, I think training, the more it happens at point of care, like taking care of patients, the better it is, because you're also delivering a service. Now, of course, with like Zoom and like the internet, I think access to knowledge has been like highly democratized, which is wonderful. But I do think that issues of directionalities really need to be addressed. I'm actually quite proud that Penn hosts many trainees from Botswana every year. I think that is wonderful. But again, the more the better.
Margaret, did you have a question? I saw your hand raised. Feel free to take yourself off mute if there's something you wanted to share.
Yes, I did. I'm thrilled to hear it. It's very abstract and it's wonderful. Full disclosure, I am retired from CDC, and I was CDC director in Botswana for 4 years. So I represented PEPFAR. I think from listening to you, I mean, you have the policy level and the abstract goals and objectives level, and then the real challenge is implementation. And people, you would ask me and I'd say creative implementation every day. That is the same as you're relentlessly approaching this stuff. So there are structural issues that you have to deal with, and there's a process on both sides. Botswana, I was also in Malawi for 5 years, and very different place, very poor place. But from the beginning, my approach, my philosophy was that sustainability was institutionalizing things. And so that and that's what we did in Malawi it was in the day, it was 2000 to 2005, and it was counseling and testing. So developing the curriculum and the policy and the monitoring and evaluation, that took much longer because they were leading it and they wanted it to be from scratch. They didn't want to take something that was already done and adapt it to their country, which is a common thing throughout Africa anyway, to adapt curricula or policies and translate them into the specific country context. But when it was done, they owned it. Nobody except American universities, I must say, would even think of doing a training without using the curriculum that the ministry owned. And unfortunately, you know, there was somebody from Penn actually who was so thrilled that doing it her way with UNC, she got 2/3 of the people to come back for their results. And I said, don't say that in public. She was a friend. She became a friend. You're crazy. If you do it the way it's done by the ministry and by the biggest NGO, everybody will get the results before they leave the facility. And frankly, I'm not sure why they're not doing that for COVID rapid testing now. But anyway, I think that in Pennsylvania, you know, there are structural limitations with the funders because you've got to spend the money by the end of the fiscal year, and you've got to spend it in the legislatively appropriate lane. So we had HIV money, and I can't say that I didn't bend that. I try, you know, but you have to stay in a certain lane and be flexible and make it work. So I think that, and the monitoring and evaluation of these issues. So I'm most interested to hear more, and I think I just to say, when I arrived, I think Penn was one of the worst partners. I think it changed a lot with Doreen Ramahola coming in. Wonderful Doreen. I don't know if she's still local director. Yeah.
No, so she was in the paper, right?
I noticed
that I quoted, and she's wonderful, and she's the deputy dean at the medical school. And and you saw that also the former CDC country director, probably after you, she was great. She's on the paper as well.
All right, well, we're at time.
The way the money is managed, and CDC's primary funding instrument is cooperative agreements, which by their name imply, and they're supposed to be handled in a way that's where both the CDC and the
Margaret, I'm going to pause you. Just
Can I answer, because she brought up some really important points. So that's what I mean. You know, we need to be like fair in our critique, because you're absolutely right. Even the CDC has really like structural like limitations that limit what they can do. My critique is really like more like on a 10,000, like more philosophical. Like, you know, some of these grants, and it's not like it's plenty of grants. Like, if you were to go to the government of a country like Botswana and said, if you had that pot of money, would you really want to spend it the way this RFA suggests it would be spent? They would probably tell you no. That doesn't mean that you can not take that money and use it to the best of your ability and make the most of it and leave lasting impact. You know, and everybody's trying to do that, including people at CDC, and I think the cooperative agreement is a great tool to do that. But like one step behind is that I don't think governments have really like a say in what these RFAs that become grants end up prioritizing.
Yeah. Well, look, we're at 1 minute past the hour. I want to just have a moment just to pause and express my gratitude, Corrado, for your insightful presentation. You know, I think what you're talking about is absolutely critical to academic partnerships. You know, and to quote from your paper, now is the time for global health partnerships to finally achieve their greatest potential to serve as catalysts for deep systemic change. And I think the question for all of us is how do we move our partnerships to that sort of transformational, you know, top of the pyramid, you know, vision that you've outlined in that paper. Thank you so much for your—
Mike, can I say one more thing? Because I don't want to give the impression that we're killing it, okay? We're trying, okay? We're really trying, but it's a struggle. It's an everyday struggle, and it's scary, and it's supposed to be scary, by the way.
Is there a way we can communicate with you after this?
Well, why don't I close out, and then people that want to stay on afterwards, we can do for a few short minutes. How does that sound? But let me tell everybody who's still on the call, next month we have Dr. Tama Aloudat, who's the Managing Director of the Graduate Institute in Geneva. Like Corrado, Taman is a leading voice in discourse around how to reimagine global health. He's a Syrian physician who's worked for many years in global health, and he'll be exploring how the global health governance systems need to change, and how we need to motivate for greater transparency around the architecture of global health governance, I guess Geneva-based governance in particular. He's a brilliant thinker, and really encourage you all to attend. So same time, same place, March 17th. Thank you all for joining. Again, Corrado, thank you so much for your time, and we'll stay on a little bit longer, Margaret, after folks who want to leave have left.
Thank you.